After the inflammatory stage, there is a fibroblastic stage where the cell proliferation occurs to enhance the wound healing, and this stage lasts from 2 to 3 weeks, and fibroblasts start to form or constitute the ground substance, and the collagen fibers cemented together. And this stage also, the local and circulating mesenchymal stem cells are transformed into fibroblasts and then to the tropocollagen, which is the primary stages of collagen formation with the main constituents of the soft tissue. These tropocollagens secrete fibronectin, which in turn stabilize the formed fibrin, which in turn attracts also more fibroblasts to the wound site and guide macrophages along the fibrin strands. The tropocollagen that has been formed undergo cross-linking together to strengthen and produce the final collagen form in large amounts, but still in non-organized or haphazard manner, which result in moderate wound strength. After increasing the strength of collagen or more organization of these fibrin or collagen strands, the wound strength gradually increases. The final stage of wound healing is the remodeling stage, where the randomly arranged collagen fibers become destroyed and replaced by new collagen fibers with better orientation, and the wound strength increases slowly but never reaches more than 85% of the original site before the wound creation. After this, wound undergo contraction, which is more excessive in case of burns. The contact inhibition is a term that describes the state of wound where the edges of the normal epithelium has tendency to stop migration from one side when it comes into contact with epithelial migration from the another edge of the wound. Significance of this contact inhibition in the oroantral fistula, as we said before, the migration of epithelial cells from the sinus floor and from the oral cavity that meet at the sinus tract, forming an oroantral fistula, as inhibition occur after meeting of the epithelial cells from the sinus with the epithelial cells from the oral cavity at the bony defect, creating an oroantral fistula. Also in the tumor cells, this property is prohibited or doesn't exist, so the tumor cells continue growing till an intervention occurs. There is no stop for growing because of the absence of contact inhibition. And in case of secondary intention healing, whereas there is a gap or defect between the wound edges, the epithelial cells grow from each side or from around the edges all around till they meet in the middle, where they stop migration, in contrary to tumor cells where migration continue unless surgical or medical intervention occurs. So there are three types of wound healing: primary, secondary, and tertiary healing. Simply primary healing, there is close or intimate contact between the wound edges, like a knife cut. There is close approximation, there is no tissue loss, and the edges are stabilized in the same anatomic position. There is no gap between the edges, so less amount of re-epithelialization occur or collagen deposition. There is few amounts, and hence there is less contraction, and remodeling and time for healing is faster than the secondary and tertiary intention, as we'll say later. And the example, like well repaired lacerations and well reduced bone fractures. There is no gap or defect between the edges. In case of healing by secondary intention, on the contrary to the primary healing, there is a gap left between the wound edges and require longer duration for healing till complete migration from the wound edges till they meet in the center or they meet together from the edges, and they stop migration by contact inhibition. And the example of wound healing by this method is the extraction sockets. There is a defect, or the poorly reduced fractures. There is a gap or deep ulcers or large avulsive injuries where there is tissue loss in the middle of the wound. The tertiary intention is usually referred to a wound that may undergo healing by second intention, but the surgeon intervened by using a graft for aesthetic reasons or for reasons of the wound is larger than normal. There is a big gap that requires grafting from another side, so the surgeons call it healing by secondary intention or by grafting the defect. Here is healing by primary intention, where there is close approximation of the wound edges, and here is there's defect or gap between the edges where the tissues or cells migrate from one edge to another till complete healing or contact between the cells from both sides. This is healing by secondary intention. Now, what are the factors affecting wound healing? Number one, the age of the patient. By increasing the age of the patient, there is a decrease in the body inflammatory response, delay in the angiogenesis or new blood vessel formation, which is necessary for wound healing, and even the process of epithelialization is slower, plus existing of several comorbidities in the patient, in the old age patient, and there is also reduced collagen synthesis, which is necessary to be linked together to strengthen the wound and to delay scar formation during the wound healing process. Systemic disease also may impair the wound healing, like uncontrolled diabetes. Nutritional status: the good nutrition is necessary to supply the necessary nutrients for the cells to perform its function. Patient attitude and the means of patient compliance or cooperation to follow the instructions for wound healing. The type of the wound: is it's infected wound. Size of the wound: the larger wound require more time for healing. Patient is instructed usually to increase the fluid intake and protein diet during healing. The fluid intake is necessary also for wound healing to supply the necessary nutrients by increasing the blood fluid level, which is necessary for transformation of nutrients and blood cells to the wound. Vascularization also, and infection delays healing, and frequent trauma like an ulcer in the oral cavity, which is subjected to continuous trauma from sharp edge tooth or sharp edge denture, where there will be delayed or no healing of the ulcer or transformation to a pre-malignant lesion due to frequent trauma to the ulcer. Also, edema may delay healing by blocking of the lymphatic drainage of the wound. Now we're going to review shortly the recent advances in the wound healing. Number one, the use of growth factors, where the growth factors regulate all the phases of wound healing, starting by the chemotaxis or attraction of the cells necessary for healing, proliferation of fibroblasts, matrix synthesis, which is necessary for strengthening the wound, and angiogenesis or new blood vessel formation. The growth factors can be applied topically to the wound to enhance healing, like fibrin sealant or fibrin glue, and it's available as a platelet-rich plasma or platelet-rich fibrin. The main difference is the fibrin is more consistent in the matrix and can be applied as a membrane to cover the wound, but both fibrin and plasma contain the necessary growth factors. Here is the difference between the platelet-rich plasma and platelet-rich fibrin. By its name, here is the fibrin content is sufficient to be released from the tube as a membrane to cover the wound, which cannot be visible from the tube. It's a fibrin matrix here, can be removed leaving the RBCs below. And here is the platelet-rich plasma in a liquid form. Can be injected but cannot be applied as a membrane. The second thing is a stem cell therapy or a tissue engineering, which involves utilization of stem cells on appropriate scaffold according to the nature of the wound that need to be rehabilitated, for development of biologic substitutes to restore and maintain improve the function. In case of wound injuries in the skin, it includes bioengineered skin substitutes that may be in the form of epidermal substitute only, which means that it substitutes or replaces the epidermal defects only, whereas the dermal substitutes, it involve or restore the more thickness defects that involve epidermis and dermis in case of deep wounds. Example of epidermal substitute includes split thickness skin grafts, which are commercially available after removal of the antigenic part of the cell, or cell lines where specific cells from the patients are harvested as a routine and preserved in cell banks. And when the patient require a skin graft, the cells are retrieved from the cell banks and cultured to form cell line necessary to cover the defect. Where dermal substitute, where the depth of the wound is larger, these cells are cultured in the lab to form more thickness of tissue to form a dermal graft from patient specific cells. Other than epidermal and dermal substitute, there is bilayer substitute, where it replaces or restores both the epidermis and dermis of skin defects, and it is commercially available as acellular bilayer, and the cell is removed for the antigenic property, and has been used successfully to treat burns and chronic wound patients. Here is a summary of the concept of tissue engineering, where the cells are retrieved from the patient either by a bone marrow biopsy or adipose tissue, or even cell specimen from bone or skin graft, where it's cultured in the laboratory and applied in a biodegradable scaffold, and this scaffold or material will be loaded with the cultured stem cells to be applied in the defect to be restored either in the bone, skin, muscle, according where the wound is existing. Thank you.